Transient tachypnea of the newborn is defined as a parenchymal lung disorder caused by delayed clearance of fetal lung fluid, leading to pulmonary edema. It is the most common cause of respiratory distress in late preterm and term infants, with an incidence of about 4 to 6 per 1,000 term births. The condition is benign and self-limited because the underlying problem is not a structural or surfactant deficiency, but simply delayed resorption of alveolar fluid. Symptoms typically resolve within 24 to 72 hours as lymphatic drainage and epithelial sodium channels clear the excess fluid. Clinically, the importance of TTN lies not in long-term consequences, which are minimal, but in distinguishing it from more serious conditions such as RDS, pneumonia, or congenital heart disease, so that supportive care can be provided without unnecessary escalation. During fetal life, the lungs secrete fluid that maintains airway patency and supports growth. At delivery, about 100 milliliters of this fluid must be cleared for effective gas exchange to begin. The transition is driven by several mechanisms. Labor triggers a catecholamine surge that switches the pulmonary epithelium from secretion to absorption through epithelial sodium channels. Rising oxygen tension after birth further upregulates these absorption pathways. Passive forces also contribute. Oncotic gradients and aquaporin channels draw fluid from the alveoli into the interstitium and circulation. Together, these mechanisms ensure that alveoli become air-filled, allowing rapid oxygen uptake. When this clearance is incomplete, fluid remains in the interstitium and alveoli, which is the fundamental defect in transient tachypnea of the newborn. In transient tachypnea of the newborn, the normal resorption of alveolar fluid is delayed. Fluid accumulates in the alveoli, interstitial tissue, perivascular spaces, and along the fissures. This retained fluid reduces compliance, making the lungs stiffer, and tachypnea develops as a compensatory mechanism to maintain minute ventilation. Fluid around small bronchioles can narrow or partially collapse them, producing air trapping. At the alveolar level, perfusion of poorly ventilated regions creates ventilation-perfusion mismatch and hypoxemia. In severe cases, excess interstitial fluid overwhelms clearance pathways and alveolar edema develops, which can impair carbon dioxide removal and lead to hypercapnia. Clinically, this pathophysiology explains the hallmark presentation of rapid breathing with relatively preserved breath sounds. The problem is not surfactant deficiency or alveolar collapse, but rather the mechanical burden of excess fluid. The mode and speed of delivery strongly influence the risk of transient tachypnea of the newborn. Cesarean section without labor is the strongest factor, increasing risk more than threefold compared with vaginal birth. The absence of labor prevents the catecholamine surge that normally activates epithelial sodium channels and accelerates fluid absorption. Precipitous vaginal delivery also raises risk because the shortened intrathoracic squeeze reduces the physical expulsion of fluid from the airways. Both mechanisms lead to greater residual fluid at birth, overwhelming the clearance pathways and predisposing to TTN. This explains why infants born by elective cesarean or by very rapid vaginal delivery often present with tachypnea despite otherwise normal gestation and birth weight. Several maternal and infant characteristics further increase the likelihood of transient tachypnea. Prematurity and late preterm birth are important because epithelial sodium channels and alveolar fluid clearance mechanisms are still immature. Maternal diabetes and obesity impair the transition through altered hormonal signaling, while maternal asthma has been linked to nearly doubled TTN incidence, likely from inflammatory and metabolic effects on the fetus. Among neonatal factors, male infants and those with macrosomia are at higher risk. Sex differences again relate to hormonal influence. Testosterone slows epithelial and surfactant maturation, while estrogen accelerates it. Protective factors also exist. Some evidence suggests that antenatal corticosteroids given at or beyond 34 weeks may reduce TTN by upregulating fluid absorption pathways, though the balance of benefit and risk at later gestations is still debated. These associations reinforce that TTN risk reflects not only delivery circumstances, but also maternal health and the infant's developmental maturity. Symptoms of transient tachypnea typically begin at birth or within the first 2 hours of life. The hallmark is tachypnea, often exceeding 80 breaths per minute. This rapid rate is a compensatory response to reduced lung compliance and increased dead space from fluid-filled alveoli and interstitium. Nasal flaring is common. By dilating the nares, the infant lowers upper airway resistance to ease airflow. Mild intercostal and subcostal retractions appear because the compliant neonatal chest wall is pulled inward as higher negative intrathoracic pressures are generated to overcome fluid resistance. Occasional grunting reflects an attempt to preserve functional residual capacity by maintaining positive pressure at end expiration, counteracting small airway collapse from peribronchial fluid. The anterior-posterior chest diameter may appear increased due to hyperinflation caused by partial airway obstruction and air trapping. Breath sounds remain clear, without rales or raunchy because alveoli are fluid-filled but not collapsed or consolidated. Symptoms last 12 to 72 hours and rarely persist longer than 3 days, which corresponds to the time required for lymphatic and epithelial channels to remove the excess fluid. Chest X-ray findings in transient tachypnea directly reflect retained pulmonary fluid. Hyperinflation is common, with diaphragms appearing flattened because air trapping occurs when fluid narrows the small bronchioles. Prominent vascular markings radiating from the hilum, sometimes described as a sunburst pattern, arise from engorged perivascular interstitial spaces filled with fluid. Fluid also accumulates in the interlobar fissures, producing visible streaks or bands. Mild cardiomegaly can appear as the heart silhouette is outlined by surrounding interstitial edema. Small pleural effusions are sometimes present, again due to fluid tracking into dependent pleural spaces. Importantly, there are no dense alveolar consolidations and no air bronchograms, which helps distinguish TTN from pneumonia or respiratory distress syndrome, where alveolar collapse and surfactant deficiency dominate. These radiographic features mirror the physiology. The lungs are air-filled but waterlogged, leading to hyperinflated yet edematous parenchyma. Lung ultrasound in transient tachypnea shows features of pulmonary edema rather than alveolar collapse. Compact or coalescent B lines extend from the pleural surface, representing fluid in the interstitium. A characteristic double lung point may be seen, where the upper lung fields appear normally aerated, but the lower zones remain fluid-filled. The pleural line is smooth and regular, contrasting with the irregular thickened pleural line typical of respiratory distress syndrome. Consolidations are absent, which further distinguishes TTN from RDS or pneumonia. These sonographic findings are useful because they reflect the underlying physiology. Fluid that should have been absorbed persists in the lower lungs, creating a gravity-dependent distribution. Ultrasound therefore provides a rapid, radiation-free method to support the diagnosis and separate TTN from more serious alveolar diseases. Transient tachypnea must be distinguished from other neonatal conditions that present with respiratory distress. Respiratory distress syndrome occurs in preterm infants and shows low lung volumes with ground glass opacities and air bronchograms due to surfactant deficiency, in contrast to the hyperinflation and fissural fluid seen in TTN. Pneumonia and sepsis cause patchy densities on imaging and are accompanied by systemic illness or positive cultures. Congenital heart disease can present with persistent tachypnea and abnormal oxygen saturations, often with a murmur or differential pre- and postductal saturations. Persistent pulmonary hypertension of the newborn produces severe hypoxemia with saturation differences between upper and lower extremities. Other considerations include meconium aspiration, metabolic acidosis, and central nervous system depression. Clinically, the challenge is that TTN mimics these more serious conditions early, so evaluation must be thorough. Correctly identifying TTN avoids unnecessary antibiotics and invasive procedures while ensuring that dangerous mimics are not overlooked. Management of transient tachypnea is supportive because the disorder resolves as fluid is cleared. Oxygen delivered by nasal cannula is usually sufficient, with a target saturation of 90 to 95%. Fraction of inspired oxygen rarely exceeds 40%, since hypoxemia is moderate and improves as resorption progresses. If oxygen requirements rise above this threshold, or work of breathing becomes significant, continuous positive airway pressure at 5 to 6 centimeters of water can be used. CPAP stabilizes small airways narrowed by peribronchiolar fluid and reduces air trapping. Alternatives such as non-invasive positive pressure ventilation or high-flow nasal cannula may be used, but trial evidence is limited. Nutrition is another consideration. When respiratory rates exceed 60 to 80 breaths per minute, oral feeds risk aspiration, so nasogastric tube feeds or intravenous fluids are safer. The guiding principle is to support oxygenation and reduce respiratory effort until fluid clearance is complete. Because pulmonary edema is central to transient tachypnea, fluid restriction has been studied as a management strategy. Some centers limit intake to 65 to 80 milliliters per kilogram per day in the first 24 hours, and small studies suggest this may shorten oxygen need, though evidence remains limited and practice is variable. Diuretics such as furosemide are not recommended, as trials have shown no benefit and potential electrolyte and renal side effects. Beta agonists, including albuterol, have been evaluated for their ability to enhance sodium channel activity and speed fluid clearance. While some studies report shorter oxygen duration or hospitalization, the evidence is low certainty and routine use is not supported. Inhaled steroids such as budesonide have similarly failed to show benefit. Clinically, this means supportive care with oxygen and CPAP remains the mainstay, and adjunct therapies are reserved for research rather than standard practice. Transient tachypnea is a self-limited disorder because the underlying problem is delayed fluid clearance, not structural immaturity or surfactant deficiency. As lymphatic drainage and epithelial sodium channel activity normalize, alveolar and interstitial fluid is rapidly absorbed. Symptoms usually improve within 24 to 72 hours, and mild cases may resolve in less than a day. The prognosis is excellent, with no long-term pulmonary sequelae once the acute episode resolves. The key clinical challenge is not the disease itself, but differentiating it from more serious conditions such as RDS, pneumonia, or congenital heart disease. Correct identification prevents unnecessary antibiotics, invasive procedures, or prolonged respiratory support. Understanding the natural course of TTN allows clinicians to provide reassurance, maintain supportive care, and focus attention on excluding alternative diagnoses that carry greater long-term risk.